Good afternoon and welcome to our second teleconferencing session. Some of you who have joined late, let me wish all of you a very happy Nurses Day, today being the 12th May, and a right opportunity for you to go through this teleconferencing session to ensure that you are able to get the right kind of workplace with a higher education and provide the excellent patient care. And that's what is the theme of the International Council of Nurses. So with that, we are going to discuss about psychiatric nursing, and basically we will be talking about therapeutic interventions. We thought we would specify that on nursing management of patient with schizophrenia. You know that one of the commonest mental disorders which occurs is the schizophrenia, and many times it goes undiagnosed because people do not understand what's happening to them. But as nursing personnel working in the community and in the hospital, when you come across a symptom of the patient, I'm sure you will be able to give advice in your own subtle manner to help the patient to get early diagnosis and early treatment before getting into the chronicity of the disease. Because you know, the more chronic the mental disorder is, difficult it is to treat, the prognosis become little poorer. So the early diagnosis will help the patient to recover, and schizophrenia being one of the commonest major psychotic disorder requires the attention of the nursing personnel as well as the health team members. And that's the reason we thought we'll discuss about schizophrenia. We have students sitting at Hyderabad, may not be Khanna Regional Center, but in Ludhiana, and we have the students sitting at Jaipur, one student, and I'm sure some more might have joined. May I request the other regional centers also to give us the attendance of the students so that we are able to interact with them, and we'll roll down the number once more for your convenience from our studio. On my extreme right, we have Miss Mitali Deb. Mitali is the faculty at RAK College of Nursing. She is one of the senior nursing person in the psychiatric nursing field and has contributed to the IGNU courses writing and also developed lot of other kind of question bank for IGNU. We have immediately right Mrs. Ravinder Kalra, who is another senior faculty at RAK College of Nursing and has been intensively involved in lot of work of psychiatric nursing and other subjects of IGNU. Welcome to the studio, and I'm sure students will benefit from both of you and will have a lot of opportunity to interact with you. We'll have the first session from 12 to 12:45. 12:45 to 1 p.m. we will have a 15 minutes break and resume back at 1. From 1 to 1:45 we'll have the second session. To start with, we are going to talk about schizophrenia as one of the major disorders, and I would request Mrs. Ravinder Kalra to let us first define very clearly what is schizophrenia.
Thank you, madam. Schizophrenia is, as madam said, is one of the most common mental disorder, and you must have seen the typical image that you have of a person who people usually call as a mad, wandering lunatics, not taking care of themselves, may not be dressed up properly, maybe sometimes just walking around nude or creating certain scenes over certain situations. That is a typical image that we have about mentally ill person, and that is what is schizophrenic also, when it goes into extreme form. But schizophrenia is not one illness, but it is a group of disorders that we have under schizophrenia. If we see to the word schizophrenia, it is derived from the word schiz and phrenia. It is split mind or the split personality. In any general population, it is said that 1% prevalence is there of schizophrenia. That means 1% people in any population are suffering from schizophrenia at any given time. If we see to the definition of schizophrenia, schizophrenia is defined as a group of disorders manifested by characteristics disturbance in thinking, mood and behavior. If we see to it, if you recall your previous experience of talking about the behavior, all three components of the behavior are being affected, that is thinking, mood and behavior. Disturbances that last for at least a month of active phase. The symptoms have to be there for 1 month at least, then only it is defined, it is categorized as schizophrenia. If it is less than 1 month, it may be called as schizophreniform disorder. But for a person to be diagnosed as a case of schizophrenia, the symptoms have to be there for at least a 1 month of active phase of symptoms, that is 2 or more of these delusions, hallucinations, Delusions and hallucinations are called the primary symptoms of schizophrenia. There is also disorganized speech, grossly disorganized or catatonic behavior. During the time when we discussed about psychopathology, we have discussed about what is catatonic behavior, if you try to recall catalepsy and all those symptoms which we are going to discuss now also, and the negative symptoms. That means they do just opposite to what is being asked for. That's how we define schizophrenia. So it is basically a thought disorder, but along with that it is the affect and the motor activity also which gets affected in schizophrenia. Now next, let we talk about sign and symptoms of schizophrenia. The common sign and symptoms of schizophrenia are: first is affect, which may be bland, flat or blunted affect or inappropriate affect. When we talk about apathy, that is that absence of affect. You must have seen certain people suffering from schizophrenia who do not show any expression. There may be anything to feel happy, anything to feel sad, but they are just sitting expressionless. They do not show any expression in their face. They do not respond effectively to any situation. That is flat affect or apathy we call, or it could be affect inappropriate. That means the affect is not appropriate to the situation. A situation demands a person to laugh at, but the person starts crying. Or a situation demands a person to become serious or sad. Somebody is talking about their death and this person starts laughing. So affect is inappropriate. The second symptom is associative looseness or loosening of association we call it. Loosening of association is that when ideas are not well associated with each other.
Welcome back, and sorry for the interruption. There is something wrong with the technical thing because the light is going very off and on, and we are really surprised today it has happened second time, the breakdown. None of the fault of anybody but of the electricity. We were talking about the signs and symptoms of schizophrenia, and you did mention that the patients have apathy or inappropriate affect. You did talk you were talking about associative looseness. Now, what does this associative looseness mean?
Yeah, when we talk about associative looseness or loosening of association, it is that the thoughts are usually going in a flow, and one thought is followed by another thought. We have a lot of ideas coming in our mind, and the ideas get associated, and that's how we come with the thought, which is something meaningful, which is expressed. But when we talk about a patient suffering from schizophrenia, since this is basically a disturbance of thought, the thoughts are not well associated with each other, and whatever the person speaks, it might sometimes be incoherent, that you're not able to understand what message the patient wants to convey, and that is what is associative looseness.
Yes, Hyderabad. Yes, Hyderabad. Hyderabad. Yes. The mark list would be on the internet, and later on you will be given the grade card status. We talked to our registrar just day for yesterday, and he said that it is getting prepared. So the grade card status card will be given to you, but hall ticket should be coming to you within a short while. Otherwise, you can also download from the internet. Keep checking the internet also, because as soon as they start completing it, they put it on the internet, and you can take out a copy from the internet and go and take the examination. I hope that answers your question. Any other question? Okay. No, ma'am. Okay. Let's talk about associative looseness. Now, could you give us one example of this associative looseness, please, in patients with schizophrenia?
Yeah. Like the patient talks about, I something. The patient what is speaking, the words have meaning independently, but once they do not have any sentence formation, and they're not associated one to another. That is associative looseness.
Okay.
Then another symptom which they present is ambivalence. Ambivalence is when there are two contradictory feelings expressed to the same object at the same time. That means feeling of love and hatred being expressed. I love my mother. No, I don't like. I hate my mother. Now, love and hatred are opposite feelings, and they are being expressed at the same time for the same subject. That is ambivalence. And another symptom which they present is autism. This is that the thinking which is not found to reality. That means the origin of the thought is from some unconscious factors. We have some thoughts coming from unconscious factor and some thoughts coming from the conscious factor. But when we talk about autistic thinking, the main origin for the thought is the unconscious mind. It may be expressed in the form of the person talking to self, that is self-muttering, or it may be in the form of mutism. That means the person does not interact. You go to the bedside, you talk to the patient, and you find that the patient is lost in his own world, not concerned about who's coming, who's going, and what all is going on in the environment. So these symptoms are affect inappropriate or apathy, associative looseness, ambivalence, and autism.
Okay. So you also mentioned that there is neologism and withdrawal in these patients.
Yeah.
Would you explain what is neologism?
Yeah. Neologism is new words. Before we go into neologism, let me say that these affect inappropriate, associative loosening, ambivalence, and autism. They are the Bleuler's 4 A's. These are the A's which were formulated in the beginning by Bleuler, and these were the characteristic symptoms labeled by Bleuler for schizophrenia. And the
which is the fifth one added, Ms. Mitali?
Thank you very much. It's added. It's called as auditory hallucination.
Okay, so that means now instead of 4 A's, we have got 5 A's, which has got apathy, associative looseness, ambivalence, autism, and auditory hallucination. Very interestingly, if you see, apathy is more of affect disorder, associative looseness is a thought disorder, ambivalence is again affect, autism is the speech, and of course it will have the thought also related to it, and auditory hallucination is perceptual disorder. So the schizophrenic patient will have the perceptual, thought, affect, and motor activity. Speech becomes a motor disorder, and you can imagine the all major areas in behavior are involved, and that is why it is called as a major disorder. You were telling some of the signs and symptoms, please.
Yeah, another sign and symptom is neologism. Neologism is new words. That means the person speaks certain words which have meaning for him, but they do not have meaning for the people around. We do not understand, we do not have any meaning for that, but when the patient says it, patient is saying with some meaning which is internal to him. And then another symptom is withdrawal, and it is mainly because of a lot of anxiety that they have. It is a symptom which comes there as a defense against the anxiety in schizophrenic patient, that the person does not like social interaction. There may be withdrawal from family members, withdrawal from social interaction, does not like to go for the job, does not like to maintain hygiene. So there could be general withdrawal symptoms seen in the patient. Another disturbance can be what we say is disturbance in behavior. That means extreme withdrawal, which may be in the form, can go up to the level of stupor. That means the patient lies motionless on the bed, does not talk to anybody, does not have any movement. The patient will be just lying still. Maybe another person has to go and give the position to the patient. Patient may not eat anything, patient may not go to the toilet, patient may just not look after any of the activities of daily living. Then there can be waxy flexibility. Waxy flexibility is that the patient's extremities can be molded in the form of a wax. That means you give any position to the patient and the patient retains that position for hours together. You have checked the pulse, you have just raised the arm of the person and left. The patient is not going to take back the arm to the comfortable position. It is such an uncomfortable one, and it may be in that uncomfortable position for hours together. Then there can be catalepsy also. That means that the patient adopts himself in some uncomfortable position. Many times it is reported that the patients who come to the psychiatric ward, the history when you collect, you might say that this person keeps standing in hot sun in hot summer for hours together. That's a form of cataleptic behavior with this show. Then there can be extreme motor agitation. The patient may be very restless. Echopraxia may be there. Echopraxia is the repetition of the movements, what the person sees. You are moving your hand and the patient also starts moving the hand. Then it can be the stereotype behavior, automatic obedience. That means usually if somebody asks us to do something, we think about whether it is required or not required. But this person may just repeat, and that may be in the form of echolalia or echopraxia. Echolalia is that whatever is said in the environment, patient repeats. You go to the bedside, you ask the patient, what is your name? Instead of telling the name, patient says, what is your name? You said, how are you feeling today? Patient says, how are you feeling today? So anything that is spoken in front of the patient is being repeated. Then there can be negativism. You ask the patient to stand and the patient lies down. You ask the patient to open the mouth and patient closes very tightly. That is negativistic behavior. The patient refuses to eat food when it is being offered. That's again negativism. Deterioration in appearance and manner. That's another symptom. Then there can be disturbance in thinking and perception. This we have already discussed about the thought disturbances which can occur, and perceptual disturbances have been talked, that there is auditory hallucination, which is the one of the A's of schizophrenia. Auditory hallucination is that when there's nothing in the environment and the person is perceiving. When it is related to certain voices in the environment, that is called auditory hallucination. Another symptoms can be disturbance in speech pattern. Disturbance in speech pattern could be when you're talking to the patient. It may be like loosening of association. You cannot understand what the patient is talking about. It could be clang association. That means the rhythmic words being repeated. It could be word salad. That means a mixture of words. The patient says one word and another word. They do not have any meaning. It is all jumbled up. So these are some of the symptoms. And some other symptoms could be related to lack of personal hygiene, not eating the food properly, loss of weight because the persons are not eating properly, also having increased motor activity, increased thought process, so there can be loss of weight also associated.
Then the one very important thing, I think both of you would agree with me, is that these symptoms will not be all present in patient with schizophrenia. There may be 5 blue-lers A or there may be few blue-lers A's will be present, but definitely there will be thought disorders. There will be affect disorder up to some extent. It may not be as intensive as we are describing in the symptoms, but the patients will have some kind of symptoms present which we are calling it as the primary symptoms of schizophrenia. Now then this will vary from the type of schizophrenia. Like some of the symptoms which Mrs. Ravinder Kalra was mentioning necessarily does not mean that all the patients would have those symptoms. These are collective symptoms which are actually in one type of schizophrenia or the other would be present. So just do not take it that all these symptoms will be present in all the schizophrenic patient. And also it depends upon at which stage the patient has come. Is it in the beginning stage, middle stage or a chronic stage? So the symptoms will get aggravated if the patient is in the chronic stage of schizophrenia, and in the beginning there may be few symptoms. It may be just patient is agitated, patient has associative looseness or apathetic attitude. It depends upon at what time the patient has come and what kind of treatment or what kind of diagnosis were made for the patient and a general physician has put him or her on the treatment. So this is what I wanted to tell you. The list given in your book does not mean that in every schizophrenic patient you will see all these kind of symptoms. It is like in all myocardial infarction. You do not see that you have to put the patient on the ventilator, but it may be a mild pain, it may be breathlessness, it may be patient is not having appetite, good appetite and tiredness. There may be other patient whose ECG will show marked changes, and also you may have to put on the pacemaker immediately. So these variation occurs like in physical illness, in mental illness too. I hope, because I thought they would go with the concept that a schizophrenic patient must have all these kind of symptoms.
Sometimes when you interact with the patient, it might be that the patient, you have started talking to the patient and you find that there is nothing wrong with the patient, and why patient is being admitted. Maybe it is a paranoid patient who is having suspicious ideas but is not sharing about the paranoid ideas. He may be having hallucination but may not talk that I hear voices. It could be that through your assessment you find that this person suddenly is looking at the wall and is being scared of something. And when you ask, is there something which is making you feel scared? And then the patient may say that there is a person sitting with a knife right on the top of the wall. So it may be your observation which is more required to identify the symptoms, and when we talk about the assessment, it will become more clear. You have to ask specifically the questions. Maybe the family members also might not be able to report all the symptoms which are present. It could be just few symptoms which are present, and initially it may be that the family members are not even able to make out that this person is suffering from any illness, or it could be that in acute phase the patient has lot of symptoms and maybe after few days the symptoms will start subsiding.
What about the psychodynamics of schizophrenia? Because there are psychic changes which keep taking place in this patient. So what are the psychodynamics?
When we talk about the psychodynamics of schizophrenia, it is said that mother-child relationship is very important in this. That if suppose in early phase of development there has been what we call it as double bind communication. That means the child getting two messages simultaneously, the child is not able to understand what is right and what is wrong. No decision may be right. Like very commonly we give the example, a mother telling the child that you go and play, but at the same time your dress should not get spoiled. You must take care that there is nothing wrong which happens to your dress. But non-verbally she is also communicating that she does not want you to go out and play. The child is not able to make out whether it is a mother wanting me to go or mother is asking me not to go. So when there is double messages being reaching to the child, or could be one parent saying something and another parent saying something. So when the communication in early childhood is not proper, then that leads to the ego development does not take place properly. If you try to recall subsystem of personality, there is ego and superego. Ego is the one which is based on reality principle, which helps in maintaining the balance between the demands, which are our basic needs, which a person looks forward for immediate gratification, and superego are the high moral values. Ego brings the balance between these two. In person with schizophrenia, it is believed that ego development has not been proper, and that is why there is distortion in the personality of a person.
Especially the significant symbiotic mother-child relationship, and that's why it is said that in the early development of personality, it is very important to have a healthy mother-child relationship, and also the parental bringing up should be very healthy, especially up to 5 to 6 years of age, so that there are no faulty relationship, and which may look to be, to people it may look to be that what is abnormal, we are doing in it, but the repercussion of it is seen in the later period of life when there are too many stresses and the person is not able to bear the stress and shows the symptoms of mental maladjustment, and that's where one thinks that where things might have gone wrong, but then it becomes too late. And that's why a lot of effort is done on mother-child bonding, mother-child relationship, especially up to the age of 6 years. Well, I hope you are clear about what is schizophrenia, what are the symptoms seen in patients with schizophrenia, what are the primary symptoms of schizophrenia according to Bleuler, and what is the psychodynamic or psychopathological changes which occur in an individual who goes through a stage of schizophrenia. Let us see what are the different types of schizophrenia. Mitali, would you like to highlight?
Thank you, ma'am. Yes, I would like to say there are few types of schizophrenia. First, I would like to start with paranoid schizophrenia. Now, paranoid schizophrenia, the word itself is giving some of the meaning. Now, paranoid word means delusion of paranoia, which means suspiciousness. So, other symptoms which you may find in such patients are like it can be delusion of persecution, it can be delusion of grandeur. Now, these all causes in the patients like he is too tensed, he is suspicious. Due to this suspiciousness, he is not able to formulate a relationship with anybody. So he goes into social isolation. So as he is suspicious, he may not be able to take his medications even. He may question why he is being given this medications. He may not even take the food.
Yes.
So all this hampers his normal activity. That means which sustains his basic physical life. So these all causes total social isolation, and finally it has also been seen that he may get agitated and he may become a violent patient. So this is one kind of schizophrenia which we call as paranoid schizophrenia. Next we can,
And I think Vitali, this is one of the most common schizophrenia.
40% of cases are seen in paranoid cases.
Paranoid schizophrenia, and sometimes in the family, they don't bring in the early stages also.
Because they are not able to identify the prodromal symptoms also now.
Yes.
So until and unless they go into acute state, then only they are being brought.
Unless or until they become so suspicious that they don't eat, they do fight with people, become hostile, as you said, they do not, the relatives don't bring to the hospital. And that's what is very important. If brought early, I think the recovery is little better. So paranoid schizophrenia, you said 40% of the schizophrenia patients are reported to be the paranoid schizophrenia.
And
Yes.
also that it occurs usually later as compared to other type of schizophrenia. This is one schizophrenia which occurs in 30s mostly. It has late onset.
Right. What is the other schizophrenia you were
Next,
saying?
I would like to talk about hebephrenic schizophrenia, which, as madam has told, paranoid schizophrenia starts later in the life, but in hebephrenic it starts earlier in the life. So, but the prognosis of hebephrenic schizophrenia is not good as compared to paranoid schizophrenia. Now, in hebephrenic schizophrenia, you will also find like there is mood is shallow. In this case, as the mood is shallow, you find that the patient is having an inappropriate effect. He might be having a self-giggling, or he is self-absorbed in his laugh. He'll give certain gestures or grimaces. He may even play pranks. So these are the few features in hebephrenic schizophrenia, and also it had been seen that there can be disorganized speech, there can be disorganized behavior, and there can be flat affect. And I think ma'am has already talked about what is disorganized speech. Now, disorganized speech can be evident by that the patient, whatever he is speaking out, it may not be distinct, it may not be distinguishable, it may not be coherent. So in other words, it is not articulate. In other words, as we are talking about disorganized behavior, here you will find that the patient is, whatever he is behaving, it may not be responsible. That means he is behaving irresponsibly, and it might be unpredictable. So this is what we call about this disorganized behavior. Now, as all of you know what is flat affect, ma'am has already talked about. So these are the prominent features in the case of hebephrenic schizophrenia.
And also, most of the time, in the ward, if there is an hebephrenic patient, you can really make it out because he's got a peculiar silly smile, which you mentioned already. They throw pranks also, and very silly smile, and it's a constant one, an infectious one.
Yeah.
So that's what is very prominent in this patient, and family actually identifies that this particular person started staying aloof, does not clean himself, does not, wear proper clothes, clothes
Withdrawn.
and keeps smiling on others without any meaning, but he has got his own thoughts which has got a relationship to smile.
Yeah.
So that's why, and as Mitali has said, that it occurs in teenage, 16 onwards, and the prognoses are not very good because these are one of the rare kind of a schizophrenia. Am I correct,
Yeah.
Mitali? Yes. Okay. What is the other type of schizophrenia, please?
Otherwise, we are talking about now catatonic schizophrenia, which is being divided into two. But before I go into the two differentiation, I would like to talk about that. In catatonic schizophrenia, you will find like there is major disturbance in the psychomotor activity. Now, this psychomotor activity you can find as it is classified into catatonic stupor and catatonic excitement. Now, there can be two different psychomotor activity disturbances. It can be hyperkinesis, or you can find stupor. As ma'am has already told, Mrs. Carter has talked about, you can also find in them automatic obedience, or you can find negativism, as madam has again told earlier. So now we come to catatonic stupor. In such patients, you will find that they are they do not have any interest. They will continuously lie. There is no body activity. When you ask,
Yes, please.
Sorry.
Call from Delhi. Excuse me.
Sorry.
Yes, Delhi. Hello. Hello, Delhi. Okay, Ludhiana. We were actually getting Delhi. Ludhiana.
Hello ma'am, good afternoon.
Good afternoon and a happy Nurses Day to you.
I am Santosh Sharma speaking.
Yes, Santosh.
Ma'am, in applied science I got 33 marks.
Okay.
Could I get 2 marks for every
No,
mark?
no, you cannot get it. So you appear in 1 or 2 papers more to score 35 marks. You cannot get that. Only if you had 34 marks, automatically the computer has that kind of instruction and gives, so you appear in 1 or 2 subjects more. Okay, Santosh? All the best. Appear in examination in June. Yes, please.
so we will continue about catatonic stupor. In such cases, you will find that the patient does not have interest towards self. So what will happen? He will stop eating. He will even hold his excretory outlet, like he cannot go for urine. He will not be moving out of the bed. So, but you should not take as if, like, as we are talking that he is not taking care of himself. It does not mean that if you tell him to take the food, he may not be taking. It may so happen that when we are not attending to the patient, he might be eating greedily. But you may find negativism in the case of catatonic stupor, as which means if I tell the patient to take the food, because in this case the patient lies down totally in the bed, he's not moving out of the bed, that is, he's immobile. Now when we give him a spoon of food, like please take the food, he may be turning his face to the other side, but that does not mean that he is not hungry. So when you may find that when you are not giving any attention, he may eat greedily. So this is one of the case in this patient, catatonic stupor, where he is not taking care of his excretion, nor his personal hygiene, nor even food eating. Next is catatonic excitement. In this case, the patient gets agitated without any motive. There may not be emotional attachment to his excitement, because many times you'll find that when we are happy, we might be jumping up and down, but that goes with emotion. But here in the case of catatonic excitement, there is no emotion attached to his excitement. So he may act out violently anytime without any reason. So this is what all about catatonic excitement.
Also, it is said that in catatonic excitement and manic excitement, if you want to differentiate, as you very rightly said, in manic excitement there will be affect attached to it. That means the patient's mood is very happy, so patient is excited, jumps up and down, paces around. But in case of catatonic excitement, the patient's thoughts are so disturbed that by provocation of somebody, the patient acts. And that's where many times the dangerous acts are performed by these people, and some of the people, even the notorious gangs hire these people then, because they are only attacking to others on the instructions of
Cold-blooded killers.
That's right. They are not able to make that kind of thought differentiation. So that's the major difference between catatonic excitement and manic excitement. Yes. What are the other types of schizophrenia?
Other types are, we are talking about undifferentiated schizophrenia. Now in this undifferentiated schizophrenia, as we have talked about these major signs, like as we have talked paranoid, there can be suspiciousness or delusion of paranoia, there can be inhibitory, whichever symptoms we have talked about. Now you'll find all the mixture of these symptoms in the case of undifferentiated schizophrenia. So such cases are being diagnosed as undifferentiated schizophrenia. So you can find disorganized speech, at the same time you can find delusion of grandeur or delusion of paranoia, so delusion of persecution. So these all mixed symptoms may be found in the patient, then only we can diagnose the patient as an undifferentiated schizophrenia.
It is also said that if the patient with simple schizophrenia is diagnosed
Another name
rightly,
is simple
and the prognoses are good.
Yeah. But practically it has been said that it is very difficult to diagnose a patient
Yes.
to be undifferentiated or a simple schizophrenia.
Okay. So what are the other schizophrenia?
Others are, next is residual schizophrenia, which I think if you have experience with certain patients in the ward, you might have seen when the patient is moving towards, that means he is convalescing, he has been treated from his acute stage, he has been discharged from the hospital. So he might have certain symptoms which may not be prominent, but such cases, but he is able to maintain his day-to-day life. But such patients with certain symptoms which are evident in them, these patients are called as
Residual.
residual schizophrenia. So that means certain symptoms of schizophrenia are still evident in him. So with those evident symptoms, they are being diagnosed as residual schizophrenia. So these are the major 5 classifications of schizophrenia. There are other symptoms or other schizophrenias also. They are called, one is called pseudo-neurotic schizophrenia, where you will also find features of obsession, features of anxiety. So these are not that very rare cases, but these certain features will be found, and then they can be diagnosed along with anxiety and obsession, along with other certain features of schizophrenia. So this is all about the schizophrenia.
There is another condition in childhood which you find schizophrenia in childhood. Would you like to explain?
Yeah, I would like to explain. But in childhood schizophrenia, it most commonly, as we are nowadays seeing, autism. Now, in this case, autism starts usually, infantile autism, which starts usually before 3 years of age. Now, in such cases, you may find that the child is used to speak out certain words without any reason, repetition of words, that is stereotypy of the words. He will repeat those words on his own, like he may not be having any, might be having his own meaning, but it may not be meaningful to the other person who is an onlooker. You may also find such patient that they are like having obsessive compulsive attitude towards his behavior. He might be repeating certain activity in a ritualistic form. So these are found in the case of infantile autism, and it is usually found before 3 years of age. If Mrs. Kalra would like to add up something.
Yes, please.
It is that usually infantile autism, when we talk about, the child is more withdrawn, may not interact that much with the parents, may not interact. Usually you find the toddlers, they love playing with the peer group. But this child may not be much attending to if there is any child of his own age group there, or may not even like to interact with the parents. It is more that the child sitting in the room, there are other people also, but this child will be just lost in his own activities, in his own world, and does not show any interaction with the people, and not much bothered about whether anybody is present or not present in the environment.
What is happening in the environment is not the concern of a child, and many times the children are more prone to accidents, because maybe there is a fire around and the child doesn't even come to know unless somebody investigates, or maybe some water is there, the child is just sitting, and the falls in the water is not even bothered because of so much of autistic involvement. Let's talk. We have talked about what is schizophrenia and what are the psychodynamics, what are the primary symptoms, and what are some of the types of schizophrenia, and Mitali has very nicely explained a bit of it so that you get a clear idea about different types of schizophrenia. Let us talk about the management, and under that I think we discuss about the medical management.
Yeah. When we talk about the management of a patient with schizophrenia, the drugs are very important. The most important problem with patients is that because of social stigma attached, they are not being brought to the hospital. They might take initially to the traditional healers, ojas and other traditional healers, and do not bring back, do not bring the patients to the hospital for treatment. Yes, Ludhiana. Yes, please.
Your question is if MSc nursing will be started by IGNOU. I wish I could give you a happy Nurses Day gift. We are trying to discuss with the President Indian Nursing Council, and I'm sure some solution will be there. And you can also write to this to the Indian Nursing Council, and let us see what kind of hearing you get as a candidate from Indian Nursing Council. We are very keen. IGNOU is supportive to it. Let the initiation come from Indian Nursing Council and all of you nurses, but the Honorable Vice Chancellor of University and the school, Nursing Discipline and Director School of Health Sciences are interested to start Masters of Nursing because there is a lot of demand coming to us to the school. We are equally keen. Let us see whether Indian Nursing Council will take any initiative like the post-basic BSc Nursing. Okay. Yes, Mrs. Kalra.
Yeah, we were talking about the management, and the most important thing is the person has to be brought to the hospital for treatment, brought to a psychiatrist for a treatment, or the patient has to go to a doctor to be able to diagnose that this person has schizophrenia and needs treatment. These days we have very good drugs available, and the prognosis of this is definitely far better than what we could talk around 50 or 60 years back, because till 1950s there was no drug available to treat schizophrenia. It was only in 1950s that the first drug, that is chlorpromazine, was started as a treatment modality for this. But now we have lot of drugs available and the prognosis is really very good. Now, first thing is, in medical management, the patient has to be brought to the hospital and it has to be the hospitalization. But hospitalization does not mean that all patients need hospitalization. Hospitalization is required only for very few percentage of cases, and it is mainly being stressed that the patient should be managed at home in the family.
So you mean to say there has to be a hospitalization if required, and integrated approach should be there of medication. Family intervention is important, and so is early treatment, and you talked about the drugs. Well, thank you very much. I think we have covered up schizophrenia. The introductory session on schizophrenia is very interesting, and you have got an overall view about what is schizophrenia. We will have a break from 12:45 to 1 o'clock, and after that we'll start on nursing management of patient with schizophrenia. Stay with us. We'll be back at 1 o'clock, and you can ask the question if you are not able to contact us in the previous 45 minutes. So we'll be back at 1 o'clock to continue and discuss about nursing management of patient with schizophrenia.